Great. Well, thank you, Zippy, for coordinating this whole thing and getting us all here today, and for all of your efforts around that. I'm Kim Dennis. I'm a board certified adult psychiatrist. I'm also board certified in addiction medicine. And I'm the chief medical officer at SunCloud Health, which is a residential PHP and IOP in the Chicagoland area. One of the units that we have is a specialty residential unit that includes psychiatry, internal medicine, dietitians, therapists, nursing, to take care of folks with co-occurring addiction and eating disorder, as well as comorbid mental health issues. And we do treat food addiction, and particularly those people who have comorbid food addiction and eating disorders. So I'm delighted to be here. I also have lived experience. I've been abstinent for a little over 24 years, from sugar and bulimia, and also sober for 20 years. That's an important part of what I bring to my work. So I, as your moderator today, will be trying to keep track of time, and introducing our speakers. I'm looking forward to a very interactive and lively discussion. We have about 20 minutes at the end, of the talk today for us to just have an open discussion with our panelists. So without further ado, I'm going to hand the screen over to Bitten, who is our first speaker. And if you could just introduce yourself, and your discipline, what you do, and then get into your 15 minutes, that'd be great. You're muted, Bitten.
Sorry. I like to share some slides after my introduction, so if you give me allowance to that. Okay. Thank you. I'm a registered nurse since 1973. I'm a recovering alcoholic since almost 40 years. I got into treatment at Capistrano by the Sea in California, the absolutely best treatment center ever. And I built my model working with sugar and carb addicts from that model. So, to me, alcoholism or sugar and carbs, same. So I worked with addiction for many, many years. I am trained in relapse prevention by Gorski. He was my mentor. I have been to many of the CCAD conferences in US, and that's where I learned a lot. And I'm certified in sugar diagnostic, Addis diagnostic, and games doing, diagnostics from the ICD-10, 11, and the criteria in DSM-5. So that's what I work with. So anyone that want to know more about me, have a ask. Abstinence or not, or pros and cons of abstinence. Okay. So what I like to say is that since only working with addiction, I don't work with anything else than addiction. And then you have to really have a deep understanding and training in addiction medicine. I also used to say I don't work with food addiction, I work with sugar and carb addiction. And I also feel in our field there are many names, labels, diagnoses of all the maladaptive eating patterns we see in society today. That's very complex and very confusing, but I mean, we all have our background, our training, our insights, our opinions, and so forth. So what I do when I work with clients is that I make sure it is an addict, and I use screening assessment and sugar diagnostics based on, the same criteria as we do alcohol and drugs and so forth. So that's what I do. To say food addiction in my world would be to say fluid or liquid addiction about alcoholism. We don't. We talk about the psychoactive drug or substance, and one has to understand the definition of what is a psychoactive substance. And then today, when I started, we knew nothing about addiction interaction disorder. We didn't talk about, the only thing we started talking about many years ago was like tranquilizers or sleeping pills, and we talked about cross addiction. Later came opioids, and then came, street drugs and so forth. And today we talk a lot about process addictions like gambling, work, sex, overeating, starving, binging, purging. And also, I don't talk about ultra processed food. To me, that is like trying to see the room through a keyhole, because that would be like, if I compare to alcoholism again, that would be like addressing vodka. Well, they are a vodka addict and not looking at whiskey, beer, wine, and so forth. So, I stay strict to the psychoactive substance and look at why does some people become addicted to that. Well, it's a genetic predisposition, sensitivity, the substance as such, an environment and exposure. And did you have it now, Sippy?
Yeah, it's up on the screen. Do you see
Oh,
it?
good, thank you. So let's go to the next slide then, please. That's a very simple model I've done to try to explain to my clients why this is so incredible, forceful, and hard. Well, most people talk about the reward center, reward system, dopamine. Well, actually, it's many more neurotransmitters that are rock and roll in the brain when you put in a psychoactive substance. So it's not only about dopamine. And this will create craving, tolerance, and addiction, which is loss of control. But we have another very, very tough player in this game for these clients that develop an addiction, and that is the reptilian brain. And if you know your triune brain, you know that the reptilian brain is the survival brain. It is ready wired when you're born. It doesn't learn from experience. It doesn't have words. It's a very, very strong survival brain, which we need. My goodness, we need it to survive. But it can take over, the prefrontal cortex, which is the first part that's damaged when the psychoactive substance come in the brain, limbic system, neocortex, and so forth. So now you have a monster sitting there driving this together with the reward system. And what's going on here is that, in the reptilian brain, you have eat, eat, eat. You have sex, you have fight, flight, freeze. So we have a very stressed client. And of course, these systems get activated. And in the clients with sugar and carb addiction, the message will be, not of course in words like this, but eat or you die, eat or you die. So this is an incredible high-strung, stressed part of the brain that needs to be understood working with addiction. One of the first things we have to do is to calm this down. And there are many, many tricks and trades and methods to do that. The best is conscious nose breathing to start working with this system. But here, with this toxic food, we have a third player, and that's the pancreas. So you also have to start understanding metabolic syndrome. What's going to happen when you overactivate the pancreas? What is happening in the brain with insulin resistance in the body? Well, the body doesn't get the fuel it needs. So, now we have a body that is in the throes of these three forces. And also remember that these clients often get scolded as children for being ravenous or gluttonous and for their body and their looks. So shame is another very toxic, stressful emotion. So they start to hide, lie, and sneak, and more shame. Well, this is briefly explained to you as you understand. Next. When doing sugar, I discovered that, the symptoms of addiction comes very early, 3 to 10 years of age. You have usually 3 or 4 symptoms according to the criteria. And then when the kid, this sugar-loving kid or my kid doesn't like real food. They like only white food or sugar or whatever, vanilla pudding. These kids get blamed for being manipulative and playing power games, which they don't. It is this brain that is starting to be hampered, rewired, faulty wired, in a way that is driving them to this behavior, which, they get scolded for many times. When we grow up as teenager, we start looking at our bodies, we start comparing ourselves, and some are, of course, very, very skinny, some are normal weight, some are overweight. It doesn't have to do with weight. But anyway, so, the skinny one could really be visceral fat, and they could feel fat because they feel swollen on the inside, which very few understand. So we start telling them they have an eating disorder instead of understanding that insulin in overload will make visceral fat inside the body and they feel fat. Looking back at pictures when they're teenagers, they're not fat, of course, from the outside. Some get high from starving, so they go into a restriction very, very hard. I've had actually a couple of clients committing suicide as anorectics or dying from it because we didn't have the tools to get them out of it. And, they had been sick for a long time when they came. I also say that as addiction specialists, we are the last house on the street. The clients that come to us are usually 40, 45, 50. They have tried everything, every therapy, every pill, powder. They've been sitting on the balcony in -20 in the bikini to freeze, to lose weight. They have done so many crazy things. So anyway, most of them cannot withstand, starving. So they go over to binging, and they are terrified of gaining weight. They get terrified of the binge. So they start purging, which can be vomiting, could be fasting, could be, all kinds of crazy remedies that they do. And many of them lose that battle too, and they go into volume eating. My experience is that it is the bread lovers and bread eaters that love volume eating. And already 2004, next picture, I met Mark Gold, and I got this, studies that he had made, and I asked him, do you think anorexia and bulimia are addictions? And he said, yes, they are. If it quacks like a duck, it acts like a duck. If it acts like a duck, and quacks like a duck, it is a duck. So, and that's my experience of doing all the hundreds and hundreds of sugars, where I can clearly see this on the curve. Next picture. And this is a picture I had from Professor Jürgen Engel, whom I had the incredible joy of working with for many years. He is an alcohol researcher. Well, he's retired since several years, at professor and psychiatrist and MD at Sahlgrenska Institute. And I got to know him, and we talked a lot about these things. So he did this showing, that, in his picture, it was nicotine paves the way for alcohol. So he saw that in alcoholics that smoked, they became alcoholics much quicker. And he meant that nicotine paved the way for other drugs. This is exactly the pattern I see with sugar and carb addicts. That, sugar is a gateway drug. And in the beginning, the client experiences a pleasurable effect. Time elapsed for addiction development. Look at this. So, they love the food. They feel very good on the food. But what's going to happen is they need to eat more and more in order to have the same pleasurable effect they had in the beginning. And now, of course, the drug, as we said in the addiction world, going to turn on them. Even though you eat more, you feel miserable, worse and worse, and you get a tremendous amount of consequences. Remember that we're talking about a physical brain illness that has physical, psychological, social, and spiritual consequences. And I feel that many out in the world, they treat the consequences and don't see the addiction behind, because the clients also always try to hide the addiction, because they don't understand they are addicts and they are shamed. But the interesting thing is, when doing sugar and sitting down and said, hey, I got to tell you, you have developed an addiction, most people cry from relief, finally somebody see me and hear me and tell me the truth. I have thought so for years, but everybody tells me, no, 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 you're not an addict. Eat less, move more, try this, eat this, blah, 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 blah. Moderation, moderation, intuitive eating, which is not going to work on this. But the interesting thing is during this, development, the cravings increase. So these people end up being drug seeking. That's why they start smoking, try cannabis, start drinking. They do all kinds of things because they change drug. And then they get relief again for a while and an effect. And then, they start doing whatever other drug. So almost all of my clients have alcohol. If you ask the right questions, you're going to find that out, that they do have problem with alcohol. They don't drink like alcoholics, but when they drink, they do lose control and get negative consequences. And that's a sign of alcoholism. So, we have to be very aware of it. And then my dear Julie Clark, she gave me a name of what I've seen is that the more years a client has this illness, the more sensitive to carbs they will be, to sugar and carbs. And that is a reverse tolerance. And she's an expert on that. So you need to talk to her about that. And when I started with the first food plan we had, there were fruit, there were grain, low fat, blah, blah, blah. It was some kind of a standard food addiction food plan. Boy, did we relapse. And then 2005, low carb came here in Sweden. We started to eat low carb, less relapse, more satiety, feeling better, increasing that. But many people, they started binging on whipped cream and yogurt and cheese and all that from cow's milk. And I don't have time to go into A1, A2 milk, but it's a very interesting topic if you don't know about it. So you need to look at that and the insulin resistance that causes. So what we discovered was in 2016, I turned into keto, a very low carb. And that's in the beginning when the keto research came. And by the way, keto research has been around for hundreds of years. I learned that with kids and epilepsy in my nursing training in 1973. But when all the pills came from the pill industry, we forgot that we could heal people with the ketogenic diet. So if you switch to the next one, dear Zippy. Okay, so when I switched to the keto for myself and my clients, we finally found much more relief, much more satiety, less relapse, and we could finally start working on all the behavior changes, how to do the brain bypass, because the drug has screwed up the brain. It has rewired it in a very faulty way. That's why we have addictive thinking, addictive behavior, addictive anything, what Craig Nacken calls addictive personality, which is a very destructive place to be, I promise you. So, in a very chaotic brain that doesn't function optimal, it's very hard to start doing the real necessary recovery work you need to go with everything that goes into that. And as we say, in the 12-step area, if nothing changes, nothing changes. That's one thing we say. And the other thing is, this is easy. All you have to do is change everything in your life. So that's what it's all about, you guys. But we have to start with the biochemical repair. We have to restore mitochondria. We have to restore energy. We have to get clarity. Then we can send them on the big journey. So keto is the drug for me. Keto is the healing power food for me. Real food heals the brain and the body. And why not start with that? If you start with a new client, is my take on this. You don't have to go through all the other hoops and loops and steps. You can just start right there. It do have some trickiness to it. It minimizes development of consequences to start as early as possible, on a client that you find has an addiction. Remember that our clients have much more brain damage than the alcoholics and drug addicts due to the very, very early exposure, extremely early, in the womb, as Cynthia is an expert on. But my babies, my clients have taken this from early on. So now I didn't have to go through all the negatives, but they're on the slide. So if you want to look, it's trickier to start people on keto. It needs much more, expertise in many more areas, and you need a tremendous amount of support. Thank you.
Thank you very much, Bitten, for talking to us about abstinence approaches and keto specifically. And now it's time for Clarissa to talk to us about harm reduction. So, Clarissa, it's all you.
Awesome. I do have some slides as well. So I'm really excited to be here to talk about this today. I am a clinical social worker. I also am a podcast host. I've participated in some clinical treatment audits on ultra-processed food use disorder, addiction, we also call it. And I think the biggest thing that I will hope to get across to you today when talking about the challenges of harm reduction is just understanding it, because I think it's so misunderstood in our field. And so today I'm going to talk about the pros, but it's mostly going to be some psychoeducation on what it looks like in food addiction clinical practice, so that I wonder if some of you might find, hey, do some harm reduction clinical work as well. So I'm just going to share my slides here. All right. So next slide, please. Okay. So while complete abstinence from ultra-processed foods can be really meaningful and empowering goal for many people in recovery, it's really important to recognize that not everyone begins their healing journey from the same starting point or with the same level of readiness. So a harm reduction approach, which focuses on gradually reducing the frequency or quantity of ultra-processed food use without requiring immediate or maybe full abstinence, can offer some real measurable benefits. Emerging research is showing that even a partial reduction in these foods can lead to improvements in mental health, in reduced cravings, increased stability, and also an enhanced quality of life. So for some, this gentler path also allows for the development of new body trust, emotional regulation, and also a deeper understanding of the function these foods used to serve for them. So traditional models really emphasized abstinence-only outcomes, but evidence from the fields of alcohol and tobacco demonstrate that reduction-based approaches are clinically sound and sustainable. And this allows us to actually broaden our definition of success in food addiction recovery, which is what we all want. It allows us to reduce shame, reduce stigma, and encourages more people to seek support. It allows treatment to meet individuals where they are, with compassion, with flexibility, and hope. After all, we know healing isn't a straight line, especially in recovery. And so I thought it was important to kind of define the concept of harm reduction. So harm reduction is an approach to substance use disorder that prioritizes reducing the negative consequences of substance use over immediate abstinence. So it's a practical and transformative approach grounded in community-driven public health strategies. This might be prevention, it might be risk reduction, and health promotion. And this empowers people who use substances or food, right? Ultra-processed food, and their families with the choice to decide to live a healthier, self-directed, and purpose-filled life, rather than insisting on complete and total sobriety from the outset. So harm reduction actually just meets clients where they're at, with compassion and without judgment, and supports any positive change as a step towards improved health. Next slide, please. Okay. So let's get clear. Harm reduction is not the same as moderation. And this is the biggest misunderstanding. Moderation suggests using a substance or engaging in behavior in like a limited amount or balanced amount. And this implies that the person has some level of control over their use and can reliably reduce it to a certain quantity and or frequency. Harm reduction isn't about how much someone uses, it's about how to minimize the harm they experience while they're still using, whether it's a little or a lot. And so in food addiction recovery, this is really important. Many people can't moderate ultra processed foods without triggering binges or cravings. So harm reduction looks like I might help someone remove one trigger food at a time. I might, help someone eat consistently, like 3 regular meals, even if they may still be, eating some other things outside that might not fit into a food plan to prevent blood sugar crashes. Maybe we start practicing mindful eating to help reduce the intensity of the binges. We replace binge foods with less harmful alternatives. All of these are very valid steps, even if they're not abstinent and even if moderation, isn't possible. Some really famous harm reduction strategies we're all aware of, and I think we're all grateful for, are things like seatbelts, right? We don't expect people to stop driving. We use seatbelts to reduce the harm if a crash happens. Condoms are another popular one, right? We don't ask people to not have sex. We're trying to help unintended pregnancy or sexually transmitted diseases. Bike helmets, right? It's like, you don't have to not ride a bike, but let's avoid a head injury. So harm reduction matters because it honors the person's autonomy. So people become the expert in their own lives. It builds trust and engagement. So clients are more likely to stay in treatment when they aren't shamed for doing it right, or there's only one way. It supports the nonlinear recovery. So it's not about being perfect. It's about progressing, and it's about making moves towards the life I want. It reduces shame and stigma. So it removes the moral judgment around food. It saves lives because people don't have to be ready. I despise that when people say that, in order to be worthy of help. So harm reduction is a science-backed, human-centered, and compassionate model that meets people where they're at. Next slide, please. So while full abstinence from ultra-processed food is really transformative for many, for others, it may not be realistic or accessible or even safe at every stage of recovery. So early in treatment, many individuals are still ambivalent, they're overwhelmed. Maybe they're not even physically or emotionally ready to eliminate all ultra-processed foods. So expecting total abstinence can shame clients. It will reinforce that rigid black or white thinking, and it can lead to treatment dropout after a slip. As someone in recovery myself, the abstinence only model that I experienced in the 12-step program created a whole nother layer of shame. And for me, it actually made me leave and not go back to the program because of the shame that I felt there. And that's just me. That was just my experience. But I am a stigma and shame smasher. So anything that is going to bring people in, allow people to be who they are and where they are and safe, is something that I'm going to be a huge proponent of. So many people in food addiction also have eating disorders. They have diet trauma, food insecurity. So making strict abstinence actually can feel like restriction or punishment, not recovery. Harm reduction offers space for gradual change and reconnection with our internal cues, right? Not that rigid perfectionism. So while clinical studies on food addiction are still emerging, we can draw parallels from other substance use disorders. So reducing exposure to ultra-processed foods can lead to improved mental health. Maybe that's reducing the binge frequency, decreasing food obsession, lowering shame, anxiety, mood instability, better psychosocial functioning. So now I have more energy to engage with my family, work, community. I have better health outcomes. So I have sugar stability, reduced cravings, and, better sleep. And what we will show is this positive behavior change does not require perfection to be meaningful to the people that we're working with. Every reduction can really help somebody start to feel better about themselves and want to continue this journey. Next slide. So in other substance use fields, the FDA accepts like no heavy drinking days for alcohol use disorder, or 50% reduction in cigarettes is tied to lower cancer, So these things, are very impactful recovery outcomes. So in food addiction recovery, it will look like reducing that severity or maybe eliminating one of those core trigger foods they've been working on, tracking the number of meals they've eaten with whole foods, and all of that. The thing I love about food addiction recovery is we're not just taking away the substance, we're also adding in nutrition, and that is going to already make them start to feel so much better. So, clients deserve to see their progress recognized, and it doesn't need to be an all or nothing. The other thing that I think it's important to note is that much like in certain drug treatments, the development of medical or therapeutical or behavioral interventions has been limited if we're only looking at abstinence. So we may not be exploring like what their other meaningful tools, like maybe these GLP-1s or, Vyvanse for binge eating disorder or, naltrexone, like all of these beautiful tools are negated when we are coming from the mindset of abstinence only. Next slide. So in food addiction, just like other addictions, return to use is not always full relapse into all the compulsive patterns we've had before. Many people who resume eating ultra-processed foods do so at a lower intensity, they have more awareness, and they often experience shorter durations of use. And what we know about the recovery research is recovery for many people, it may take people 8 years to get 1 year of abstinence. Now, during that period, there's going to be multiple interventions, there's going to be multiple returns to use, and each of those are an opportunity for learning and experience and growth. And if I'm somebody who's only looking and considers success only when I get that complete abstinence, I may decide to give up before. We always say, don't give up before the magic happens. So harm reduction is a much more loving approach, I find, in allowing the individual you're working with to explore their why and like what happened and how can we now next time do this differently. So recovery is a spiral. It's not a straight line. And each return to use really strengthens commitment and can deepen some of our emotional regulation skills. Labeling clients as not ready or non-compliant or resistant is one of my least favorite things. If anyone is doing this in clinical practice or coaching, please stop, because food addiction is we would say a chronic, relapsing condition, but it's intensified by trauma, shame, and metabolic disruption. So programs that are rejecting or saying this client isn't ready or they're in denial, which I'll talk about soon, are really shaming. And this forces the person that we're worked with to go back into that secrecy, the lying, hiding, sneaking. So it also doesn't acknowledge the world we live in, because we live in the most food saturated world. And this ignores the reality of our clients who are surrounded by triggers all the time. So a return to use is not resistance, it's the learning curve. And treatment should remain open and adaptable during our setbacks. Next slide. So UPFs can result in wide-reaching physical, mental, and social benefits. And due to my time, I'm not going to go through all of them, but a reduction in use is not a lesser goal. It's a meaningful step towards long-term healing. So when people know that perfection isn't expected, they are more likely to begin treatment, stay in treatment, and return after a setback. So harm reduction is really just meeting the client with curiosity. It affirms their dignity, their agency, and their growth rather than compliance. And so this model, I find, builds therapeutic trust because it really decreases the shame, which is a critical ingredient for long-lasting change. So if the door to recovery is always open, people are more likely to walk through it. And, harm reduction in ultra-processed food addiction isn't a compromise. It's a clinical necessity that acknowledges recovery is messy, Progress is personal, and every reduction in use is a win for the individual and public health. Next slide. It's my last slide. So to me, this is really important because we have to meet clients where they're at, not where we wish they were. And this is something I see in clinical practice all the time. It's, well, you need to be doing this or you need to be doing that. And we don't know what's best for clients. And so when we label a client as denial, it is, it may seem like, oh, this is denial. This is what I'm seeing. Can you go back, Zippy? I'm not going to show that slide just because of time. It's really saying you're being resistant, you're being immature. This is your willful ignorance. And in truth, what we're seeing is a lot of fear, maybe some ambivalence with the clients, and self-protection. And we're going to challenge them on that. So in trauma-informed care, we recognize that people are going to protect themselves until they feel safe enough to do otherwise. So start asking yourself, what might be at stake for this client if they let go of that food? What are they afraid they'll lose? Is it their sense of identity, their comfort, or their control? So this creates space for curiosity over confrontation, which is a place I think we need to come from, and collaboration over compliance. It allows us to build trust. We validate their lived experience. We let clients define their own goals, their own values, and we reduce shame, which is the biggest driver of return to use. So clients are going to be far more likely to engage in the recovery process when they feel respected, when they feel like you're hearing them and you're offering them options. Thank you.
Thank you so much, Clarissa. It's wonderful. And now I will hand the screen over to David Wiss to talk with us about integrating treatment models for the next 15 minutes.
Right on. Thank you, Dr. Kim and Clarissa and Bitten. Really thrilled to be here. I see several friends and colleagues. Hope to make some new friends today. And I'm going to just dive into, some of the pros and challenges of trying to think in the both and rather than the either or. It's a lonely place to live, right? And I think we've done a good job. I say we because there's several others that are interested in seeing the world through the lens of the continuums and the spectrums rather than the binaries. But I will say that binaries are easier. It's much easier to pick a tribe, pick a lane, pick a message, and just get behind it. It's better to scale businesses that way, whether it be treatment or online. It just seems to be the easier, softer way. And the middle ground is very, very difficult socially and emotionally. And so, yes, I am a clinician. I do counseling. I do functional medicine for mental health. I am a mental health scientist, and I am a tech founder of the Wise Mind Nutrition app. I have a background in alcohol recovery going back to 2006, and I got very interested in rigid messages of recovery. They really helped me, and I'm crystal clear that when I got in to recovery, and it was throw the Listerine out, tiramisu is a relapse. And it really helped me. It really, really did, because I remember thinking about it as leave no wiggle room. If there's room to wiggle, I will wiggle. And it really helped me to commit to a path of, abstinence-based recovery with alcohol. And I remember, getting really enthusiastic about the literature and hearing things like there's going to be some things that you must do. And I'm like, yes, tell me what I have to do. And there was concepts like there are people that are the real alcoholic and people that are kind of just moderate or hard. And I just took a lot of pride in being like, yeah, I'm the real one. You guys aren't. I'm the real thing, and feeling very committed to my path. And so I guess I'm just paying homage to rigidity because it saved my life. You know what I mean? And I appreciate it, and I understand it on the deepest level. I think when I, became a registered dietitian and I got into the field of nutrition for mental health, I started dabbling around in the eating disorder world. And there was, a lot of different messages, that were coming out of, intuitive eating and food positivity and body positivity. And a lot of it also resonated with me. This idea that it didn't have to be one way and that there was a lot of different possibilities, and this idea of relax, your nervous system is just dysregulated and uptight. It also really resonated with me. And I liked the message of stop tripping and stop seeing the world through the lens of, one experience. And I can say that I quickly noticed there was a dichotomy in the food world between food addiction culture and eating disorder culture. And it felt deeply polarizing to me, and it felt deeply disturbing to me. It almost seemed like the gaps were widening over time as food addiction literature started to proliferate. I noticed that the pushback increased and people were digging their heels in certain positions to almost be the opposite of the other. So when I think about extreme versions of food addiction recovery and extreme versions of eating disorder recovery, you could truly pit them against each other and really draw out like the polarities. As these are like, one group is saying, there is, problematic foods, there is, weight to be lost, there is a need for restriction. And it's true for some people. And there was this opposing view that said the opposite: no food rules, stop losing weight, restriction is your disorder, etc. And so I think my journey has been a journey to reconcile some of these differences, because I know that it's impossible that one is right and the other is wrong. And if I were feeling this way, I assume that a lot of my patients and clients were also feeling this way, that they were feeling like pulled to one side or the other. And if they didn't fit in, where were they going to go? So that's when I was like, I want to be a place for, people to go that are more interested in the nuance of it all. I also noticed that addiction, particularly food addiction culture, was heavy on biological sciences, right? The understanding the mechanisms, the dopamine pathways, etc. Whereas, eating disorder culture looked a lot more at the psychosocial aspects of food and body and weight. And, I was fortunate. My doctoral training was in biopsychosocial sciences. So thinking about how to integrate all of the things. Davina's here. My 3-year-old daughter has made an appearance to show her outfit. And the view that I always had, getting into some of the pros of integrated models, is that integration is more realistic because it reflects what actually happens in people's lives. In other words, diagnoses tend to cluster and co-occur with other diagnoses. There's very rarely an addiction or an eating disorder without, a couple other quote unquote comorbidities. And so when we look at things through diagnostic boxes, I think it can be dangerous. One of my favorite lines is, if all you have is a hammer, everything looks like a nail. So if you are like a trained food addiction professional, and this is, you know the biology, and you're looking for food addiction, you're going to see it everywhere. You know what I mean? And if you are an eating disorder professional who is trained in understanding diet culture and how that, is pervasive and permeates society, you're going to see that everywhere. And it was pretty obvious to me that people from those two different camps could look at, one person and see their training. This is called discipline bias, right? And so the inclination, I think, is for someone to want to treat the person with what they know. And that makes sense. This is how treatment sort of occurs. The other line that I want to share that I've always appreciated is that all models are wrong and some of them are useful. Is that we have these different models for understanding and explaining phenomenon, right? And none of them are actually capturing exactly. They're just explanatory models. Some of them are more useful than others. So I've always been very careful not to say, okay, I've got this framework by which I view the world, and everyone is going to, fit in here and I'm going to do my thing. I've tried to be a little bit more scientific, seeing things as like a color palette, right? If you were to think like from light pink to dark red, every single little color along the way, it's just how my mind thinks. I see an infinite range of possibilities when I look at, issues and I look at people. I see continuums and I see spectrums, and not everyone is prepared to think or talk in this way. If someone's in crises and they want a professional to just tell them what to do, they don't want to learn about the infinite shades of pink to dark red. You know what I mean? They want a food plan. They want to know what meeting to go to, right? So there's a lot of challenges with thinking this way. And it's a little bit less of a crisis management approach and more of a outpatient, long-term, sustainable approach where you're forcing people to think on their own. Because another one of my favorite lines is, well, you're going to be an eater for the rest of your life, so it's like, it might be in your best interest to like put a little thought and to put a little effort into thinking about how you're going to navigate as you evolve and grow over time, right? And I will say that there are people that don't want the multiple counseling sessions to understand their own, psychological profile on a deeper level. They're looking for something a little bit more immediate. The famous, I want one session and I want to pay the bill, I want to pay the invoice and have my problem solved sort of mentality, right? I was really hoping that at the end of our 50 minutes, you'd have the plan for me for the rest of my life, doc, that sort of thing. And I don't try to be the person for that. I want to be the person that's going to help people understand that their relationship with food and body is going to evolve over time, that they're going to grow, and like in the rigid version of me that comes from AA, had the point of view that like, like I said, if you have this condition, then this is what it must mean. And this is therefore what it'll always mean. And I just no longer take that position. I do believe that context matters a lot, and that there are some people who can find a chunk of truth at some point in their life and have that be different 10 years from now. And those are like scary thoughts for people. And I'm not necessarily saying that, I think someone who's been, sober for 10 years should, try drinking, but like some people can, and some people do. And I think that's an important thing to think about with respect to food, right? That it's contextual, it evolves over time, and that I don't get to be the arbiter of other people's stuff. So my integrated approach to treatment is with more questions than answers, if that makes sense. I really try not to be, I'm the expert because I have this training. This is the lens by which I view the world. It's like just deeply curious, providing psychoeducation, science, asking questions, encouraging recovery. And the part that I've always thought was deeply missing from the food addiction space was the emphasis on positive body image. And I know that a lot of people here do some really good work in that space. So I'm not making a broad generalization, but I think it's one of the ick factors that a lot of the eating disorder field has when confronted with the food addiction space, which is like, this is just weight loss in disguise, right? And I always like to incorporate body image, contextual factors, and also a big part of what I like to do in an integrated treatment model is really look at developmental processes and build a timeline of, you know, the onset of challenges and psychiatric disorders, health events, etc. And so, yeah, I think that overall, integrated models are more invested in long-term outcomes. Integrated models meaning models that are built to be fluid. You guys in health, metabolic, we use the term metabolic flexibility to describe like someone who's able to shift between different macronutrients and in different circadian rhythms. That's like a sign of really good health. If someone has metabolic flexibility, and I think that, you know, one could argue that psychological flexibility is also a really good sign of mental health. If someone has one way of being and everything else is difficult and turns into a disaster, to me, it's not a marker of great mental health. Thanks, Kim. I also know that there are people on extremes. There are people that need to make sure that it's 500 grams of vegetables and not 505. Okay. I understand the value of that so deeply. I understand why there are people that are anti-diet, that are angry at diets and are pissed off at people who believe sugar addiction is a thing. I understand where that comes from too, right? And so to be able to hold everything simultaneously true and then meet people where they're at, it's a really, really good long-term outcome. And to start wrapping up, the challenges, as I mentioned, are that sometimes the short-term outcome is difficult and patients are frustrated because they want a group to identify with. They want to know, you know, what hashtag are they searching for? Like, we need to know what is the tribe. And and it's challenging for people and they get frustrated because there is a deep longing for a group identity. And, you know, when you do stuff that's very, very nuanced, as I mentioned, it is harder to like scale the message. You have to do a lot of kind of one-on-one work. But I guess as a healthcare professional, and I'll sort of close with this, I feel like I have a responsibility to be invested in people's long-term outcomes over their short-term outcomes. That is like part of my oath as a healthcare provider, is that I want to give you the tools to thrive in the big picture so you don't have to see a nutritionist again. And to not be predatory, to not, you know, sort of capitalize on people's wounds, to be a safe place and to not be the expert. You know what I mean? Even though I might be, to just be the coach in the corner, the shoulder to shoulder, let's walk, let's find recovery. And I guess, yeah, to wrap up, I believe that an integrated model could involve something like 12-step recovery, addiction therapy, you know, using the Wise Mind Nutrition app, having a nutritionist and doing little things from all the different areas, but having it look completely unique to that person's journey. And most importantly, letting it evolve over time based on one's being in touch with their sort of internal cues and whatnot. That was fun. Thank you, guys.
Thank you, David. As a eating disorder professional and a food addiction professional, I want to just say thank you for being on the very lonely island that it is to be a person in both worlds. So now we have, I'm going to say 6 minutes. So 2 minutes for each of you. If you have further thoughts, starting with Bitten and then Clarissa and then David. Any final thoughts, 2 minutes each, to lead us into the Q&A portion of today? Anything from you, Bitten?
Not more than a lot of what they both talk about is included in the addiction model during different parts with the relapse prevention and everything. And I see that as a client that has a severe illness and it is a medical intervention. So, I make sure it's an addict I work with, and then I apply the correct treatment for a severe illness. That's all.
Awesome. Thank you. And Clarissa?
Yeah. So as a harm reduction clinician, I am meeting the client where they're at. And what that also includes is abstinence. If that's what they come and that's what they're seeking and that's the support that they require, I'm going to meet them exactly where they are and support them in that. So, because I am a harm reduction clinician doesn't mean that I don't do abstinence with just as many clients that I work with. It's probably 50-50 for the most part. And that really, when we think about harm reduction for most people, the goal is abstinence. So it's just loving them and helping them and supporting them to get there along the way.
Thank you, Clarissa. And David?
I guess I'll use my 2 minutes to share my 2 slides.
There you go.
Okay. I've worked on this, and maybe you've seen it before, but I've created a, can you see that, or do we lose it?
No, it went away.
It went away. So I'll try one more time. Maybe it is right. Maybe it wasn't meant to be. Let's just do it this way. Let's keep it simple. The food addiction versus eating disorder debate. Eating disorder centers on the assumption that the more you try to avoid it, the more likely you are to crave it. Whereas food addiction centers on the assumption that the more you eat it, the more likely you are to crave it. So eating disorder views restriction as the driver of pathology. The restriction drives the binge, whereas food addiction sees consumption as the driver. The addiction might drive any of the dieting. And I guess it didn't advance on your end. Here we go. Eating disorder emphasizes the psychological and social factors in society that contribute to body ideals of thinness. That's the psychosocial piece. Whereas food addiction emphasizes the neurobiological factors of each individual that contribute to problematic eating. Eating disorder views weight stigma and diet culture as the key drivers, whereas food addiction views the food environment and the way that food changes the brain as the key drivers. Eating disorder treatment looks at the forest of the diet rather than the individual trees, and food addiction treatment recognizes how important individual trees can be in the forest ecosystem. That would be the actual ingredients. So eating disorder view teaches inclusion with all foods fit, and food addiction understands that some foods can be triggering for some people and are better off excluded. And the eating disorder philosophy teaches acceptance, how to navigate the food system we live in, and the food addiction philosophy emphasizes change, ways to opt out of the system. So the eating disorder view doesn't see food environment as a target, whereas food addiction view sees public health policy regulating food manufacturers as a target. And lastly, in eating disorder, weight stigma is the social justice issue needing to be addressed, and other issues seem less important. Whereas in food addiction, at least from a public health perspective, prioritization of private profits over public health is the overlooked social justice issue. Eating disorder believes changing anti-fat attitudes is the solution, and food addiction believes that challenging corporate greed and political power is the solution. So hopefully that dichotomy is helpful to anyone that feels caught in between the worlds.
Thank you, Dr. Wiss. And I will say from my center, we do have a paper in preparation right now that shows, one of the big arguments against food addiction in the eating disorder world is it's going to cause or worsen dietary restraint. And we actually have data showing from our center that dietary restraint decreases for people with eating disorders and food addiction who are exposed to food addiction, psychoeducation, and treatment options, including harm reduction options, abstinence options, or all foods fit, eating disorder treatment as usual. So there's a lot. There's a lot that each of you have shared. There's a lot that I'm sure each of us as clinicians in this space face day in and day out.
If you like what you heard today, please remember to like, comment, share, and subscribe. Thank you for watching.